I would say probably putting your feet in water. Certainly, putting a potato on your head. I've heard a lot of people say, take a potato or an onion, a raw onion, and put it on your head, and it sucks away the migraine. I think those are some good ones. I think that they kind of, harken back to times in the old country where people really weren't sure what was going on. If you really wanted to kind of go back into migraine myths that have been around for centuries, poking a hole in the skull
Right.
to release the migraine coming out. It'll release some spinal fluid and probably brain and blood brain tissue also. But I'd say those are some of my favorites.
I love that. I definitely like the idea of an onion sucking away the migraine. That was like kind of cool, especially those ones that go on and on and on. I think my favorite one is sticking a banana peel on your forehead because potassium is supposed to be good for you. So somehow you absorb
Yeah.
enough potassium from the banana peel on your forehead. But I always think that that's hilarious. But we do crazy things. People of migraine do crazy things, don't we? Just to try to get relief. And so we laugh, but I actually know people who do some of this crazy stuff. And I've done some crazy things too because we get desperate. So
Very good.
yeah. So how prevalent are myths and misinformation about migraine, aside from the funny ones, which are all over Google, right? And all over social media? How much do we actually see just kind of some serious myths and misinformation out there that could be problematic?
I think it's everywhere. And the problem is so many people know a little, and a little bit of knowledge sometimes leads you into a terrible direction. So sometimes people will say something like, well, it's all about blood flow, so you have to do this thing about blood flow. It's all about inflammation, you have to do this thing about inflammation. These myths are everywhere, and unfortunately many times these myths are sometimes even like promulgated by what seem to be otherwise legitimate sources, people who, will give often, very legitimate medical advice with regards to other things, but because they really lack the understanding of some of the basics with regards to migraine, they will recommend things that have no basis in evidence whatsoever.
Yeah, interesting. It's really sad. Why do you think that is the situation? I mean, why is
Yeah.
there so much misinformation out there?
I think a big part of it, even among people who might be a board certified physician or somebody who probably should know better, a lot of it is just that the education regarding migraine and other headache disorders is very poor, even in medical school. I was at NYU for years, the sole 1 hour of headache education that medical students, and NYU, by the way, is, depending on the year, the number 2 or the number 3 medical school in the country. So the curriculum is actually a curriculum that many other medical schools follow. There's an hour of lecture on headache disorders. Migraine is the majority of that. If you were to ask the vast majority of medical students during their neurology rotation about cluster headache, even, they probably heard maybe about 5 minutes of a lecture with regards to cluster headache, and they know something about it. They really don't know nearly enough about something that they really need to know a lot about.
Right. Absolutely. And I think that really sums it up. They don't know a lot about something they really need to know a lot about. And we know
Right.
that, we hear in our group all the time people saying, my doctor told me this and my doctor told me that. And then just asking us, is that accurate? Or not even asking us, just saying what you're telling us in this group is wrong because my doctor said, and we're going to deal with some of those things today. And I think that
Yes.
the biggest concern for me is that so many people think that if they go see a neurologist, they've had extensive training and ongoing training in headache disorders. And that's just not necessarily true, right?
Unfortunately, that's the case. Even neurologists who see a lot of headaches, sometimes they're not very familiar with the most, first of all, updated understandings of like the pathophysiology of migraine. And they're almost never familiar with The evidence-based lifestyle approaches that can be helpful in, augmenting whatever medication they're going to be recommending. Oftentimes they're stuck in the same approach, especially if it's somebody who's been around for a long time, the same approach to migraine that they had in the 90s. And things have changed. The 90s are 30 years ago. We unfortunately see patients doing poorly, not because they saw something on TikTok that they're following, but because they've actually been told the wrong thing by somebody who probably should know otherwise.
Right. Absolutely. It's so sad. And, we see, I'm sure you see the ramifications all the time. We see it in our community. Every advocacy organization sees the ramifications. People get desperate, they get hopeless, suicidal ideation, end up in the emergency room when they shouldn't necessarily be there. Just so many things that go wrong, or just not getting diagnosed and not getting treated at all. And that's just really desperately sad. I'm actually going to add a question that I just see came in on our live event, which is great because it means it's working. So thank goodness for that. We were able to resolve the technical issues. But one of the myths is that people who have chronic migraine are drug addicts. And so when we seek help from the pain, we are drug seeking. So the question is, first of all, we know that's not true, but hopefully you're just going to say that's not true. Why do so many pain doctors and other doctors treat people who have migraine as drug addicts?
I think that many times people who have migraine will be presenting to their physician in a desperate state, because we'll talk a little bit about some of the features of migraine that make it so difficult to live with migraine, especially if it's very frequent on a daily or very, very frequent basis. Sometimes doctors are like, well, what do you want me to do already? And they don't always have the correct empathy and patience to understand what a person who is experiencing especially frequent migraine, what their day-to-day is really like. And oftentimes, if somebody themselves has a low frequency of migraine, they don't have that same perspective. Or if they don't see on a daily basis people with chronic migraine, high frequency migraine, debilitating, disabling migraine, they might just say like, hey, I get headaches too. We hear this all the time. I'm even somebody who gets migraines sometimes, and I can live with it. I take something and I get over it. And not having that same, I would say, empathy is where the problem starts. And so much of it also is, if you don't set up a patient for success by offering multiple different kinds of acute medications, right, then the patient who's going to be limited by their insurance, if you give them only one type of treatment, legitimately or not, it's a discussion, then you're half treating their attacks. If it's somebody who's experiencing 20, 25 days of attacks and you're giving them 9 tablets of sumatriptan, I mean, nobody would do that for any other condition. Nobody would do that if a patient had hypertension every day of the month. And we're going to give you 9 pills of your antihypertensive. I think that's where a lot of it comes from. It's this complete and total misalignment.
Yeah, it's interesting. I like to say, I love that about hypertension. Also true about epilepsy. Would you tell someone who has seizures, has multiple seizures a month, and sorry, we can only give you 2 or 3. You just had to go through the rest of the seizures untreated. Nobody would do that at all, right? It just seems to be special for migraine, and we're treated differently. And that's really frustrating, obviously. So one of the myths we have here is people with migraine look fine, so they can't be in that much pain. Let's talk about that.
Migraine is an invisible disease, and people with migraine don't walk around with a crutch. They don't walk around with a sling because they, tore their rotator cuff. I find it, very shocking and disappointing, where if you were, in an elevator with somebody and all, they tweak their shoulder's in a sling, you'd hold the door open for them. You'd be like, oh, please, Meanwhile, somebody might, they may even look like they're experiencing something. Maybe they're in the throes of an attack. They have, their shades and baseball cap on for migraine. Maybe they even have, an ice pack and they're walking around and they're trying to do the best that they can. And people don't have that same empathy. They don't even, feel like they should go out of their way and try to help them. Oh, do you need help getting down? Do you need to sit down for a second? Can I get you something? Even in a doctor's office, these patients are treated sometimes so remarkably differently. Oftentimes people with migraine are trying to do the best that they can, and you try to put on a happy face and you try to, and it becomes a double-edged sword where you are trying to get to as functional of a level as you can, and that works against you, where people are like, but I see that you're showing up, but I see, aren't you okay if you showed up?
Right.
So that's where it comes from.
Yeah, which kind of leads us into, really our next question, which is that migraine is just a headache and people make too much fuss about it. Honestly, I don't normally hear the latter part of it, but it's kind of implied, why did you cancel? Why are you going home? Why aren't you at work? Again, it's always why, and it's just a headache. What would you say to that, myth?
A lot of times that comes from a place that most human beings experience some kind of headache at some point in their lives. Not everyone experiences hip pain. Not everyone experiences back pain. Not everyone experiences neuropathy or any other kind of joint issue. Headache is a human experience. There's a reason why it is that idiom. It's a headache, right? This thing that I have to do when people are trying to say it's something that they don't want to have to do, something that's a bother. And most people, especially if they've never experienced migraine, think that migraine is just a bad headache, right? It's, I've had some really bad ones sometimes, just like I've had some ones that aren't so bad. So, don't make don't make it into your identity. Don't make it into something that is an excuse for not spending time at work with your family. That's where it comes from. And I think right now, the phrase to really use is migraine is not just a headache. It's more than a headache. So in other words, instead of saying, migraine is, it's more than headache pain alone. And I think a lot of people have to understand that there are the sensitivities that are a prerequisite to the diagnosis of migraine: light and sound, GI issues, smell sensitivity, motion sensitivity. And I would say the hallmark of all of it, which is something that we're going to get to in a little bit, which is, by definition, the more that you try to do, the worse that you get. It exacerbates with physical exertion. So trying to push through it, trying not to make too much of a fuss, about it, trying to be as functional as possible in the throes of an attack will actually make the attack worse.
Right. Yeah. Quite a distance from being told, just walk it off. Right. And some of the other, I mean, I've been told crazy stuff ever since I was in school, because mine started so early. And some of the things the school nurse would say to me, it just, you wouldn't say it to anybody else with any other condition other than migraine. And it's really devastating. But let's dig a little bit deeper into pushing through, because that's kind of a common theme. People not understanding why we can't push through, but more than that, I think ourselves feeling like we should push through, and kind of dabbling in the area that, migraine is kind of a progressive disease. You may phrase it differently. So, I'd kind of like to know your thought on that. But I think I saw a post from Neura Health, something like the more headaches you get, or the more migraine attacks you get, the more sensitized you get, and so on. So maybe we can address that a little bit, and why it's not always a good idea to push through these attacks.
I think treatment is extremely important. And when you talk about pushing through, especially if you aren't doing something about the attack, one of the things that we're starting to see is that actually makes the attacks worse. For decades, people with migraine have been told medication overuse, medication adaptation headache, you have to make sure you're not treating too often. And there was a landmark paper that came out just, I'm going to say, 2.5 months or so ago, just in time for the big American Academy of Neurology conference, that talked about medication under treatment. Medication, instead of medication overuse headache, medication underuse headache. So often not allowing or doing something to, abort the attack actually makes the attack more difficult to treat and makes migraine itself more refractory and harder to sometimes treat long term. Under treatment oftentimes is associated with a higher frequency and worsened severity of migraine. And there's a scientific basis to this also. The pain matrix, the areas deep, deep, deep in the brain, become what we call sensitized. We call this central sensitization, where they are so used to being bombarded with pain signals that no matter what, something else that's, eventually being sent is perceived first and foremost as, oh, here's more headache, here's more pain, being sent, to the brain, and it becomes this self-perpetuating cycle.
Yeah, absolutely. And, I mean, obviously I experienced that with attacks that just once they go past 3 days, it's like it's almost impossible to stop them. And so I just want to let people know before we go on to the next question, if you're out here, if you're watching this either now or in the future, and you have multiple migraine attacks that do not stop, if they are really seriously impacting your quality of life, if you've seen multiple doctors, maybe tried multiple medications, I just want to encourage you not to give up. Talk to an organization like Neura Health and ask to see one of their doctors, see who's available under your insurance. Sometimes it's worthwhile just paying outside your insurance just to get on a good treatment plan. We do also have a website that shows every single certified headache specialist in the US. Just because someone says they're a headache specialist doesn't necessarily mean they are. And we're actually going to deal with that a little bit later. So I didn't mean to kind of jump into it, but there you go. Sure. Let's talk about one of these things that I think a lot of us hear when we first go to see a doctor, and you say, I'm getting these headaches, and he'll maybe diagnose you with migraine. He will maybe give you one pill, but then he gives you a list of things to stop doing. So like, don't eat chocolate, don't drink red wine, stop drinking caffeine. It's a myth, obviously, that all migraine patients are the same. But what would you say to someone who's hearing that from their doctor or friends and family?
I think so much of it comes from this perspective of actually blaming the patient first. Well, if you are experiencing migraine, clearly it's because of something that you're doing. And you then have to stop doing X, Y, or Z that I can still do. And that will magically and mysteriously stop all headache attacks, stop all migraine, and you'll be fine. There's actually a very interesting study that came out of the Danish Headache Center in, like, I'm going to say, early 2000s. And it took, I'm going to say something like 15 to 20 people that had specific triggers. These are people who really did have very specific triggers for their headache attacks. They said, every time I have red wine or caffeine or whatever it would be, put me in this situation, 100% of the time I'll experience migraine. So they did that. In a vacuum, they exposed the person to whatever it was, chocolate or red wine, the thing that always triggered their migraine attack. And 0 out of all of those patients experienced migraine in a vacuum. And what that basically says is, even when there's very, very consistent triggers, it usually isn't the trigger alone that is leading to that migraine attack. So much has to do with the context of what's going on. And listen, if you do see that very consistently, every time you have a specific thing, you tend to experience, a migraine attack, then it would be a wise thing to avoid that specific thing. But that isn't the case for most people. And most people really do need highly individualized recommendations. There really isn't a one size fits all, treatment, even when it comes to things like diet. There really isn't a migraine specific diet that's helpful. The best that there really is an association between higher intake of omega-3s and improvement in migraine. That's not really a diet. All of the elimination diets, actually, and again, a landmark review study looked at every elimination diet specifically tried for migraine, did not show significance.
Right. Interesting. Yeah, I know that a lot of us find that really frustrating when someone would say, well, this worked for me, or my doctor told me I have to do this because this will stop your migraine attacks, and it really makes you feel just kind of like a number, because suddenly we're all supposed to be the same. And that's really not true for so many diseases, but especially for migraine. It presents on such a wide spectrum and variations that it could be really hard. I remember one of my family members telling me one time, I just don't believe that migraine is that disabling. He says, never had anybody from my work ever call out. And when I get a migraine, as in that person, I just take something from the pharmacy and it just goes away. It's easy. So maybe in one migraine a year. And I think that's part of the challenge, is that people just don't understand that migraine is really not the same for everybody, and really believe in that. Like, maybe theoretically they do, but it's hard for someone who doesn't have very severe migraine to understand how bad migraine can get. So here's another myth that we have here. Now I see some live questions. I actually have questions coming in on 2 different Facebook pages. So if I'm not answering your question, don't be afraid to put it up again, and I'll try to get through them all. But so this myth is, if you don't have an aura at the start of your attacks, then it isn't migraine.
There are a significant percentage of people, about 25 to 30%, that experience aura where, that precedes their migraine attack. Some people have migraine with aura. Most people actually do not have aura with migraine. So a lot of this comes from the fact that people think, classically of, visual distortion or, phenomena or some other, aura symptom that precedes their headache. And that happens to many people, but actually to the minority of people. By definition, migraine actually occurs, migraine without aura, without an aura, as the name implies. So that is 100% a myth.
Right. Interesting. Yes. Good to know that. And the aura isn't always the same. It's just, even if you do get aura, it can be radically different. So someone here is saying, not necessarily kind of a myth, but I'm just going to ask the question anyway. How do you determine whether dizziness during a migraine attack is strictly vestibular migraine, as opposed to just a symptom in another type of migraine?
That is such a fantastic question. So first, to just define terms, vestibular migraine is a subtype of migraine where at least 5 times historically, you've had attacks that have some, what we call vestibular symptom associated with it. When people use the word dizziness in English, it can mean a bunch of different things. There's a spinning kind of sensation that the technical term is vertigo. There is a rocking on a boat kind of sensation. There's lightheadedness, which is more like your head is floating away. Or you can have what we like to call disequilibrium, which is every time you try to walk, the floor just feels like it's foam. It just doesn't feel solid. Technically, any of those symptoms can allow your diagnosis of vestibular migraine, as long as you also fit about 50% of the time that you experience the vestibular symptoms, you also are experiencing pain that has some features of migraine: the one-sidedness, the throbbing, the moderate to severe pain, how long it lasts, some of the sensitivities, etc. You need a couple of those things, not as strictly defined as your regular run-of-the-mill migraine. So how would you differentiate that between somebody who maybe has an ear infection that specifically is a virus that infects the inner ear nerve called vestibular neuritis? How would you differentiate that from somebody who may have the little rocks in their ears that moved out of place that causes a spinning sensation? We call that BPPV, or some other more nefarious causes of vertigo, like stroke or MS, that sometimes can be presenting. A lot of it is based on going to your doctor and telling them the story and telling them, this is what it's like when I experience X, Y, or Z. And so much of that history has the answer to what that, what the situation is. If you're somebody who has fairly frequent migraine attacks, many of those are superimposed with vestibular symptoms. The likelihood is going to be much higher that it's vestibular migraine. You may go to your doctor and they may not even be sure. And they may say, you know what, we need to send you to an ENT to get specific kinds of hearing and vestibular testing done. And we need to get an MRI to make sure that there isn't a problem with your IAC, with your internal auditory canal. And they may not be able to make that diagnosis right away for you either.
Interesting. So not an easy answer. And, I have a couple of people in my volunteer team, amazing people who have vestibular migraine, and it's challenging. I hear the journey they go through. It's really rough. So there's somebody who put a live question here, says that they were on Aimovig. They had to stop taking it for whatever reason. Their doctor said, if that one doesn't work for you, or if that one causes side effects, then they will all be the same. So implying that if you take one medication in a class, one CGRP inhibitor, then none of the other seven, I think 7 others, will work for you at all. So don't even bother trying.
Yeah, I definitely take issue with that approach. I don't think that we even see practically and anecdotally that that's the case. There actually have been some small studies that looked at switching CGRP type medications, and we definitely see, the handful of studies that have been done have shown that even people who haven't benefited from one specific type of injectable will benefit from another type. Understanding the different kinds of CGRP medications, it makes sense because even though they all do the same thing in the end, they do that a little differently. Aimovig, for instance, is something that blocks the CGRP receptor on your body, as opposed to the other 2 injectables and infusion medication. All of those block the actual protein CGRP that's floating around in your bloodstream. The orals go about it in a completely and totally different way. They're not antibodies that are trying to find CGRP anywhere. They're metabolized by your liver into a medication that blocks also that same CGRP receptor. Different medications 100% have different side effects and different efficacies. So I would tell you that, trying one, especially, depending on how long you've given it, it may be that you do need to give it a little bit more time. It may be that switching from one to the other can be, the answering can be helpful.
Right, absolutely. And I know for myself that I went through 5 different CGRP inhibitors before the 6th one actually has been partially helpful for me. But so many of us get told, don't try another one. It's not worth your time doing it because one hasn't worked for you. And that's just not true. And we see that in the other classes of migraine medications as well. Just to remind people who are watching, if you want to put live questions in, then please go ahead and do that. And we'll try to get through them. We have a few others that I have already, but we definitely have time to take more. So actually, we actually just addressed the question number 11 that I have here. Let's go on to the next one. People do not need prescription medications or devices to treat or manage migraine.
I mean, you're lucky if you don't. And many people walk around with a low frequency episodic migraine, and they, infrequently take something over the counter and they do well. Some people are able to implement some kind of either relaxation type therapy like biofeedback or something else that's helpful, and that becomes their primary preventive, type treatment. And if you're like that, that's fantastic and that's amazing. Most, I would argue, but certainly of the people that are here with us are people that really do need preventive and acute treatments when it comes to migraine. And everyone is different. And for some people, it's a device, and for some people, it's medication, and for some people, it's injections, and for some people, it's a combination of these things and lifestyle modifications. Everyone is different. What works for one person, even genetically, if they're very similar, will oftentimes not necessarily work for someone else.
Yes. And also we see obviously that sometimes the medication will work for a period of time. and then just stop working. And sometimes for a long period of time, I know that there's been some discussion at the American Headache Society conferences about this, trying to figure out why. And I like to say it's kind of like migraine has AI. It's like as soon as I find something that works, it's like, ha ha, got you. It's not going to continue working, but that can be really hard. So we have a question here. If the new CGRP inhibitor drugs, those are the ones since 2018, do not work for you, then you do not have migraine. And we do hear this in our group sometimes, which is really sad.
I think that's also a misnomer that comes from people who understand a little bit of, regarding the pathophysiology of migraine. And what they hear is oh, CGRP is super important in propagating migraine. And if you block it and you still have some kind of headache, it's not migraine. And it comes from a complete and total misunderstanding of the pathophysiology of migraine. CGRP is one of a whole host of inflammatory neurotransmitters that propagate migraine. It's definitely helpful for many people when you block CGRP one way or the other, but it is not diagnostic in any way whatsoever. There is not a diagnostic tablet, even a triptan, anything that's specific for migraine. None of those are diagnostic for migraine.
Right. Which is it's frustrating that there isn't anything diagnostic for migraine, but on the other hand, it's really important for people to know that and to be able to respond to your doctor about that. And it's very frustrating, obviously, because as patients, we kind of had this impression that our doctors, they know everything. And if we go to them, they're going to be able to give us accurate answers, and they're not going to give us inaccurate answers. Sadly, specifically for doctors that have not had training in headache medicine, that's just not the truth. You talked about having your 1 hour at NYU on migraine. And I think about the amount of time that people who live with migraine spend researching and studying and learning and attending. And it just makes that 1 hour in medical school seem really sad, to be honest. Let's go on to one of my least favorite myths. And that is that migraine is just a women's disease. I'm particularly passionate about dispelling this one because I have 3 sons, all of whom have been blessed with my migraine genes, unfortunately. So what would you say to that? Migraine is just a women's disease.
Migraine is definitely higher in incidence, female to male, and it's about 3 to 1. That said, oftentimes men are undertreated or mistreated when it comes to migraine. I mean, oftentimes women are too, but many times men are misdiagnosed as having cluster headache, which has a higher incidence, male to female, and migraine definitely happens in a high percentage of men as well, just not as high of a percentage, as women. If you look actually at ages of presentation in little kids, it's about 1 to 1, boys to girls. It's about the same, 50-50. And older adults, there's even a slightly higher predominance in males, slightly, because women often, although not always, tend to age out of migraine, or at least have a lower frequency once they reach and go through menopause, although that's not the case for everyone. It's during reproductive ages where things really split apart, and a lot of it is due to hormonal fluctuation, which we know, especially estrogen, is something else that significantly influences the frequency of migraine.
Right, absolutely. Thank you for sharing that. I appreciate it. We have a couple of questions here. They're a little bit off topic for today, so just kind of want to let folks know there's a question here about blocking CGRP if it doesn't help. Is there anything else in the works? I would definitely encourage you to go to our website, migrainemeanderings.com, look at the toolbox, and there is a section there that says clinical pipeline. I'm always updating it. I probably haven't updated it in the last couple of months, and things are constantly changing, so I need to go back and update that again. But if you're looking for hope for something new, go check that out. Someone here who asked about, the CGRP medications don't work, what to do, or if you have intractable migraines. Dr. Berk has done actually 2 really amazing interviews for us exactly on that topic, and we will put the link to those YouTube videos in the chat afterwards, so you can just take a quick look at them. So next question is, hot one again. Migraine attacks will stop for women after menopause.
So I kind of stepped in this one. Doesn't for everyone, but there is a certain percentage of women, especially if you're somebody who has a very strong trigger related to your menstrual period, especially also if you're somebody who has improvement during pregnancy and breastfeeding, that profile, which is, I would say common, but not necessarily universal, does tend to have improvement after menopause. That does not mean that you experience zero attacks after menopause, but it means that even if you're somebody that, in your 20s and 30s and 40s, you have a relatively high frequency, there is the possibility, if you're somebody who had those kinds of patterns, that as you get into your 50s and beyond, things may improve. Nothing is ever a guarantee, but that is something that we see for many people.
Right, absolutely. There's kind of a double-edged sword, and we see this with when people try new medications, is that you want to hope, you want to not give up. It's really important to hope. But when you hope for something and it doesn't actually happen, in many ways, it's like, I hear people, and I felt this myself, why did I even bother hoping? Because it didn't happen. But it's important to hold on to hope. That's what I would tell people. Just always hold on to hope. I've been told my whole life, maybe when this happens, your migraine attacks will stop. When that happens, they will stop. When that, and for me, they just haven't. But I choose to hold on to hope, and that is one of the reasons why we have the clinical pipeline on our website. Going to a conference next week, always hear amazing information about upcoming clinical trials and things that are in the offing. So please, yes, you do not give up hope if you have migraine attacks and they are just not being well managed or managed well at all. Let's talk about essential oils. So this is the myth. I just have to give a big sigh with this because so many people have shoved essential oils in my face, and I'm one of those people like, oh, please don't. So the myth is essential oils are great for stopping or even preventing migraine attacks.
I'm not going to say that there is no evidence whatsoever for using essential oils in any way. I think that especially when it comes to something like peppermint oil, there actually may be some anti-inflammatory effect. There may be some benefit even acutely, either with using aromatherapy or potentially something topical for things like eucalyptus and lavender oil. That being said, comparing something like that to an actual acute medication is night and day. Things that are specific for migraine will end a migraine attack much more quickly, much more effectively. And I would say importantly also, there really is no evidence that any of these things can prevent any attacks at all.
Right, absolutely. So again, it's just kind of, you need to figure out what works for you. But if someone tells you definitely by using essential oils, migraine will get less frequent or you'll be able to stop your attacks, unfortunately, it's just not necessarily true, unfortunately. We wish that it was true, but things like that don't work like that with migraine. So let's look at this question that just came in. And that is that migraine is always one-sided. And so if your pain is not one-sided, it is not migraine. And you'll notice that with a lot of these myths, the similarity for those who are listening is very definitive. It's black and white. And if you listen to Dr. Berk talk, he's obviously explaining that there is nothing really that's black and white with migraine other than it's a horrible disease to have. So are migraine attacks always one-sided?
A hallmark of migraine is that more often than not, pain is worse on one side than the other. If you experience consistent pain on the same side always, it's probably something else. There are hundreds of other kinds of headache, subtypes also. And sometimes we actually will try to give you a diagnostic type treatment for things like hemicrania continua or other one-sided, uniquely one-sided headaches. One of the things that we say about migraine is that migraine migrates. It almost always will move from one side to the other. And it may be that your left or your right side
Right.
is where more of the attacks happen, but it's almost never the case. It can happen, but it's almost never the case that your attacks are always stereotypically in the same place on the same side, and that's migraine. So we
Interesting.
think about other conditions, sometimes even secondary headaches, if it's so specifically localized.
Right. Yeah, that's very interesting. I know that my migraine attacks switch sides. If they're on the right side, they're almost always going to be the worst ones. So I know I've just got to stop what I'm doing completely. If it's the left, it may be bad, it may not be bad. And then for the ones that just don't want to stop, it's pretty much my head feels like it's just exploding all over, which I know is a common feeling for people as attacks go on. So another question we have here is, if you see a chiropractor, well, I'm rephrasing some of these questions for those of you who are wondering, hope that's okay. But if you see a chiropractor, they will be able to heal your migraine attacks.
Yeah, we unfortunately have some issues with chiropractic manipulation. One thing that I would say just about every neurologist will tell you is, some of the scariest patients that we see coming in during our training through an emergency room are people that have had some kind of chiropractic manipulation above the shoulder, and that's torn internally some of the great vessels that go up to the brain, the carotid or vertebral arteries, and that causes a dissection of the carotid or vertebral arteries, and that can lead to a stroke. And oftentimes, if this happens in young, otherwise healthy people. Young people really should not be experiencing a stroke. And sometimes these can be lifelong deficits that people have. That doesn't mean that every time a person goes to a chiropractor, they are inviting some terrible, outcome. But it does mean that even in the hands, unfortunately, of very, adept chiropractors, bad things can happen. Oftentimes, chiropractors can also make recommendations that go against evidence-based treatments. I will say that there are some chiropractors that are excellent and that have, a good track record with regards to medications, don't click and clunk your neck. But I would be cautious about putting too much weight in the recommendations or treatment of a chiropractor.
Yeah, absolutely. Thank you for making that clear. It's good to know. I love this one. If you just avoid your triggers, you'll be fine. It's kind of part of the blame and shame game, right? What would you say to that?
That's exactly it. We talked a little bit before, specifically about trigger avoidance and how trigger avoidance has not been shown to be helpful in avoiding attacks. Sometimes you're just avoiding life. Many of the things, by the way, that trigger migraine are things that you do every day and that everyone does every day. It's like, well, it's the weather. I mean, even if you moved to the middle of the desert, there's weather there sometimes too. And sometimes the weather is violent over there. So, avoiding triggers oftentimes doesn't really get you nearly as far. And being on an effective preventive regimen, more often than not, will actually allow you to be less sensitive to the triggers that seem to more frequently set off a bad attack.
Right, absolutely. And I see this comment, I think it's Canon that's put in it there, that says there is nothing wrong with needing comprehensive treatment. Migraine is not your fault. So if one of your big triggers is scent, it's very difficult, if not impossible, just to avoid it. What we've got to do is go to a grocery store, stand behind someone at the bank, or sit next to someone on the plane. You just cannot avoid it. Maybe you could just touch a little bit on, I know it's kind of off topic a little bit, but about the concept of stacking triggers.
A lot of times people have, different ways of visualizing triggers. And I think one good way of thinking about it, people say stacking, people talk about a migraine threshold. There are different ways
Right.
of, talking about the spoons. I mean, there are different ways. And I would actually reference our most recent Instagram post that talks a little bit about this concept as a whole also. When you have a predisposition for migraine. It's a genetic predisposition. That means that you can experience migraine. That means that there's a certain threshold that when that gets crossed, your brain flips on into migraine mode. And oftentimes, different things will contribute to that threshold being lower and sometimes being higher. What you want to try to do is get yourself into a position where you have as high of a threshold as possible. So that way, even if other things come and that would normally set you off, that would normally trigger an attack, you may not necessarily get to that threshold. So that to me is the best way to kind of think about it. And oftentimes the same things that will affect your threshold and make it lower and lower, the opposite of those things will make it higher. If you're sleeping poorly, if you're more stressed, sometimes even something like alcohol, right? When people will have some of those triggers, it's all of those things coming together that then get you to cross that threshold and flip the switch into migraine mode. People who oftentimes have chronic migraine have a very, very low threshold to begin with, and there's always something brewing and bubbling there the whole time.
It's an interesting phrase to use, brewing and bubbling, kind of feels like that, definitely. And I think one of the useful things that I find myself and people on my volunteer team find is that if you know what your triggers are, at least if you know what some of them are, and you get exposed to one of them. So let's say, it's barometric pressure and you wake up in the morning, there's a storm, then that may not be the day that you want to go walk through department stores where there's perfume being sprayed everywhere, or you'd be able to put an errand off to another day. So it's not just that I don't want people to feel helpless. There are some things you can do to help yourself. Not a lot, but there are some things, and I always say any migraine attack that you stave off is good. Any attack that you could stave off. So even if it's just one a month, it's definitely worth it. Let's talk a little bit about the concept of a migraine action plan. So I guess the question for this, or the myth for this, would be all you need is one acute medication for migraine, and that's all you need to get from your doctor.
I mean, you might be somebody that's lucky enough that you experience few enough attacks that you'll get enough of that specific treatment from your insurance company.
Yes.
And it's so consistent for you that you take it and you're good. And if that's the case, just like with so many other things, that's fantastic. That's great. Many people, especially if your frequency is higher, many people need either multiple options with regards to what to even use, because if they only had one thing, they would run out of it very quickly, or they need options for using as a first line and then potentially a second line and maybe even a third line type treatment. It really depends on your unique situation. You might be somebody where you have, like you mentioned, one side that's, that implies a more severe attack. You might be somebody where some of your attacks are more associated with vertigo and vestibular migraine, and others are, without any aura, and different acute medications may actually be more helpful for you in different scenarios. You might be somebody where when something happens, you need to treat it as aggressively as possible, as quickly as possible. And if you delay, you're left with days and days of migraine also. So depending on your unique situation, you might be somebody who, is going to alternate different medicines as their first line treatment. You might be somebody where you'll be given one option and then told, wait an hour or 2 hours, repeat that dose, take another medication in a different class, take a third medication. If you're still nauseated on top of all of that, you might be somebody where we say, take 3 things in 3 different classes right away, immediately. And even one of those could be like a non-oral treatment, like a nasal spray or an injectable, just to get that, migraine to have finished as quickly as possible.
Right, absolutely. That's really helpful to know. And just to give kind of a quick plug for a resource that my organization is finalizing right now, actually about to send it to you, Dr. Berk, to get your feedback on it.
Hey.
And that is a migraine action plan. We know the AHS actually had one, but it was done more than 5 years ago. So it's definitely a little bit outdated. And we just want to be able to offer that resource to our patients. So give us a few weeks to get some feedback from our medical advisors like Dr. Berk and make sure that it covers everything. But the whole concept of that is that you could go to your doctor, give them this migraine action plan, and make sure that you don't leave his office or her office without having a comprehensive plan for your attack. So if you know that you end up in the emergency room a lot, or even occasionally, talk to your doctor about what to do when the first migraine medication doesn't work or the device doesn't work. Talk to them what happens if the second one doesn't work or the third one. At what stage do you really need to go to an emergency room would be the question. So there's the concept of having a comprehensive plan is really, really important for so many people with migraine. Not everyone, as Dr. Berk has mentioned, but for a lot of people it is. I know we only have a few minutes left now. If anybody has a question that I have missed in the comments, please repost it. Or if anyone has a new question, then please repost it as well. And I have just 3 more here on my end. So we kind of touched on this, but I'm going to say it again. So the myth is all doctors know how to treat migraine. So it doesn't matter who you go to, you're going to get the same experience.
I think it matters significantly. And we talked a lot about education. We talked a lot about experience. If you go to somebody who just doesn't have that background, and sometimes, by the way, the education is how to be empathic to your patients, how to understand where they're coming from, how to believe a patient when they say that they're experiencing this many attacks and this is what they look like, and these are the things that work and don't work for them. I think it makes a huge difference. When we hire anyone, when it comes from, all the way from, MDs to NPs and PAs to coaches, to even, our, kind of support staff members, we look specifically for how people can be empathic, how, they can understand, because we're all, talking to patients on a daily basis, how we can, is this somebody who will be able to express empathy to a patient and meet them where they are?
Yeah, absolutely. And it's interesting, although probably logical, that I would say that the headache specialists I've seen who are the most empathic are those who also have migraine themselves. It's not, strictly true for everyone, but that really is. There's just a difference, right?
Very true. Very true. And the one thing that I would say is the incidence of migraine among headache specialists is almost 100%. I mean, it's I think one study, it was a small one, it was like 97% or something like that. This is a self-selected group of people.
Right, absolutely. Because when you grow up with migraine, you really get passionate about needing to make a change, right? And you realize how little help there is. I just posted our headache specialist websites in the comments. So if you need to find a headache specialist, you can take a check out there. But just to give you kind of a brief bird's eye view, we have approximately over 40 million people in the US alone with migraine, and there are less than 1,000 headache specialists in the country. That includes people who are certified through the UCNS, which is only available for neurologists. They've taken that additional certification and ongoing education as well. And then the AQH, which is through the National Headache Foundation. It's the same thing. You have to take not only extensive headache education, but also ongoing headache education. Not everybody has access to one of these doctors, obviously, which is really sad. But if you're seeing a doctor and you're not getting anywhere, it's always worthwhile having a second opinion. Just kind of speak into that. So last 2 questions. This is the first one. What is the most concerning misinformation about migraine that you see or hear?
That migraine is your fault.
Yeah.
That by far is the worst. Anything that even implies that you did something to bring this upon yourself, that by far is the most dangerous. Needless to say, are there other, ridiculous things like people say, pour hot water on your feet, boiling water on your feet? Seriously, from an emergency room doctor? Yes, that's dangerous too. But there are things that are, dangerous in a number of different ways. And I would argue long-term hearing that migraine is your fault is very, very dangerous.
Right, absolutely. I wrote a blog once that basically said, please believe me. And that's all I want. I know every time I go see a new doctor about anything, in my head, it's just, please believe me and don't blame me for what is going on, with my body. And, when people do get blamed, then they're less likely to be compliant. I don't really like the term compliant, but with their treatment plan, they're less likely to keep seeking out help for their migraine attacks. They're going to get more depressed, more anxious. It's just a downward spiral. So I 100% agree with you that it's a very dangerous one. And then just to end on a positive note, what are you most excited about in the world of migraine right now?
You mentioned, upcoming and new treatments, upcoming and new understandings of migraine. I think part of it is better understanding of the genetic basis of maybe even certain phenotypes of migraine, different people with different subtypes. We talk about, people present differently. Maybe there's a reason why. And we're barely starting to scratch the surface, but we're getting somewhere with that. And also, just like we have some targeted migraine treatments that focus on CGRP, there are many more targeted migraine treatments that are going to start focusing on other inflammatory molecules like PACAP, PACAP. There are two different subtypes of that, and that may even be more beneficial for people who have migraine than CGRP. So that's very exciting.
Yeah, I find it very exciting as well. I'm constantly trying to get the latest and the greatest on PACAP and the other ones. I know that PACAP's just finished another phase 2 trial, right? But it hasn't started phase 3 yet.
Is gearing up.
Yeah, it's super exciting. And all the advocacy organizations are working on this. We work together, we partner with the industry, with pharmaceutical companies to get the most information. We partner with doctors to get you the most current information. And there really are some exciting things that are coming up. So I just wanted to say thank you so much for everybody being here today. Thank you, Dr. Berk, for coming back and working with us again and sharing all the information. I hope everyone here has found this helpful. If you have any comments or questions that have not been answered in this live event, please let us know in the comments. It was a little challenging today because we went live in 2 different places at once, but trying to track all the comments, it was a little challenging, but hopefully, we got most of them. Migraine can be such a challenging disease to live with, and we encourage you, as always, to proactively partner with your doctors, explore different treatment options, and create an action plan to help manage the disease that you live with. Thank you so much for joining us today, and have a great day.